consultant, Alfonsa Eye Hospital, Todupuzha. He did his glaucoma fellowship from UK, and he has special interest in neuro-ophthalmology. Over to you, Dr.
Thank you. I'd like to thank AOS for this opportunity. My topic is swollen disc with blurred vision. Dr. Kale's talk has made my work quite easy. These are a few cases I've seen over the last 22 years, and you can see the appearance of the swollen disc can be very variable, and equally the etiology as well was extremely variable, as you can see here. So how do you go about finding out and narrowing down the possible cause of the disc edema? So this is my consultant, Mr. Barr, who I used to work with in UK. This was his list. This can be used for any medical condition. So this is the list he used: inherited, neoplastic, vascular, inflammation, infection, immunological, toxic, endocrine, degenerative, and of course in an unusual case, in this case, hypotony. So these are different possible etiologies that can cause the disc edema. And if you see the pictures I showed you earlier, so you can see here, you got inherited, inflammation, infection, vascular, neoplastic. So all the different etiologies are listed here, degenerative. So all the different etiologies can present to us, and we need to narrow them down. Of course, you can have a disc with normal looking disc with a reduced function. It's an optic neuropathy, and Dr. Kale has just covered papilledema in detail. So in one case, one situation, you have normal appearance with reduced function. Here, abnormal appearance but normal function. But here we're dealing with abnormal appearance and abnormal function. So approach is just like any case, history has a great role in examination and investigations. Pseudodisc edema, Dr. Kale has already covered. Make sure it's a true disc edema. So this is a rare set of photographs, 2008, 2015. This patient had a photograph because of a suspected RNFL defect, but she came 7 years later with the disc edema, and you can see all the different changes: the color, the cup, the contour, the circulation, and the surrounding retina. All the changes in the appearance you can see here. So examine the disc with the 5 C's and differentiate true versus pseudo. The most useful I found as the cup and the vessels. The vessels are seen very clearly over the disc in pseudo edema. And then of course whether it's unilateral or bilateral, because the etiology can be quite different. Unilateral, you're thinking something like posterior scleritis, optic neuritis. Of course, any of these conditions, if they left over time, they can become bilateral. Bilateral presentation, you think of papilledema, systemic causes, systemic drugs, and important role of the history. So you just mentioned, you asked for the sudden onset of blurring. With pain, you think of inflammation, but if it's painless, you think of vascular. Gradual, you think of a compressive lesion. And of course, other things like numbness, suggestive of demyelination, history of malignancy, drugs, coagulative disorders, all these are extremely important, not in our usual ophthalmology case. This is a patient I saw while in the UK, and her only complaint was she cannot see this rim and this rim of her glasses. How observant she was. And when I checked the fundus, this was the appearance. So this was an AION affecting the inferior and nasal part of the disc, causing the corresponding field defect. And then on asking history, she had all the features of jaw claudication, polymyalgia rheumatica, she had ESR, which is very high, and the positive temporal artery biopsy. So the history is very suggestive that it's a vascular cause. Of course, examination as well, the checklist of examination, do a brief neurological examination as well as a routine ophthalmology examination, all the tests of the optic nerve function. Blood pressure, please don't forget. And this is a case Dr. Kale has actually shown. This is a case of the lumpy, bumpy appearance, suspected papilledema. And sometimes if you have access to, most of us have access to a fundus photograph, you can just put the camera on the fluorescein angiogram setting and take a photograph, and you see the autofluorescence of the optic disc, drusen. And if you're really doubtful, you can either do a B scan or CT scan, or in this case, an FFA was done, and you can see the disc is staining beautifully but not leaking. Moving on to true disc edema. So this is a case of a patient again I saw in the UK, blurring of left eye for 3 weeks, and you can see there's a marked disc edema. Right disc is absolutely normal, and just before I put the patient on the slit lamp, I noticed this fullness in the temporal fossa, and so I suspected a bony lesion, and a CT scan showed a fibrous dysplasia. So I just want to highlight that nowadays with the increasing use of slit lamp, sometimes we put the patient straight on the slit lamp, and subtle findings like this can be missed, which will save you a lot of trouble. Investigation, the blood investigation you need to do, of course, immunological tests as well, and appropriate imaging, MRI, and bony cases suspected, then you think CT is probably better, and then of course in some situation you need to do liaise with the neurologist for an LP. So again, a patient, 47-year-old, slightly on the higher age group, and presenting with blurring left eye. You can see the disc margin is blurred. So all features suggestive of an optic neuritis with decreased optic nerve function. But important to understand is that if it's typical, they should behave in a particular pattern. They usually worsen for 2 weeks and start improving by 4 weeks. You can see exactly by 2 weeks she has started improving. So typical optic neuritis should behave in a particular pattern. Otherwise you should think of atypical optic neuritis. We heard a beautiful talk earlier. Again, a 41-year-old carpenter, blurring of vision left eye, history of cat scratch about 2 months ago. You can see the disc edema and also the associated edema of the adjoining retina. So this is a neuroretinitis, and had a very good response with systemic antibiotics and systemic steroid treatment. Of course, if your findings are beyond the disc, so you mark it cortimal spots extending everywhere, then you think of a systemic cause. Again, Dr. Kalei showed so this is a patient with a blood pressure of 210 by 130. Again, always examine both eyes. The patient with complaining of blurring in the left eye, left disc edema, and the other eye was a pale disc. So this is a case of, this is a Foster-Kennedy syndrome, or pseudo-Foster-Kennedy syndrome. You can only differentiate by doing an MRI. So this was actually an AION with presented. So always examine both eyes. Even though the complaint is one eye, always examine both eyes, and then that will help you in narrowing your diagnosis. Again, a patient I showed you earlier with the disc edema. So when she came in 2015, I made a diagnosis of posterior scleritis. She responded very well to systemic steroids. At that point in time, I actually did not examine the other eye, and she came in 2019 with a blurring in the left eye, and she had an X-ray to retinal detachment. And you can see now, in 2019, appearance of the right eye, and this has become a sunset fundus. So you can see over a few years, the diagnosis revealed itself. It was a case of BKH, which there might have been findings in the left eye at initial presentation, which I did miss because I did not examine the left eye. So always examine both eyes, and that will help you narrow your diagnosis. 16-year-old girl, 11th standard student, present with some complaint of headache, and when examined, she had features of panuveitis, and you can see serum A's was extremely high, Manto was normal, and then we made associated with the physician, we made the diagnosis of sarcoidosis, and we started systemic steroids. We did not actually get a tissue diagnosis because they were reluctant for a biopsy, and they also did not do a CT thorax, but all the blood tests were done, and MRI was also done to rule out any mass. And then we started on systemic steroids, probably a little reluctantly, and then on treatment, she developed hemorrhages, which showed, and also she developed a facial palsy. So, but fortunately, we were able to tie all together with the clinical diagnosis of sarcoidosis. So you had features of ocular sarcoidosis, the disc edema, and on the features of panuveitis, and now she had features of neurosarcoidosis, the facial nerve being the commonest nerve involved in facial nerve, and the optic nerve are the commonest nerves involved in sarcoidosis. So she had new vessels on the disc. We actually increased the steroids. We actually gave her a PRP as well, and she had a very good response. You can see the initial appearance, and now how she looks. And last patient, again, Dr. Kalei has covered this. This is a patient with bilateral disc edema, and as she said, venous sinus thrombosis. One risk factor, of course, is dehydration, and this patient was also on oral contraceptive pill. So the two risk factors for possible thrombosis, dehydration and OCP, and she came with double vision and blurring, and that is because of the sixth nerve palsy. And all cases of papilledema, you have to do an MR venography. So you can see the MRI here. The superior sagittal sinus is thrombosed, and fortunately with appropriate treatment, the recanalization happened, and you can see the flow after the recanalization has improved significantly. So in summary, take-home message is do a detailed history and drugs, history of malignancy, some things we miss in routine ophthalmology cases, focused examination, true versus pseudoedema, unilateral versus bilateral, blood pressure, don't forget, general and neurological examination, and do the appropriate investigations, blood and imaging. Thank you.
Thank you, Dr. Thomas Arun. That was a lucid presentation.